Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're in session number 2, which is part B of session number 3 of our new series entitled Instability Syndromes and the AMA Guides. And let me see if I can clarify that just a little bit. In this series, we're discussing the instability syndromes and the permanent impairments associated with instabilities of the upper extremity, of the lower extremity, and of the spine. And the AMA guides provide for generous permanent impairment ratings in those examinees who demonstrate bona fide ligamentous laxity and joint instabilities of the major articulations of the upper extremity, the lower extremity, and also the spine. And in session 1 of this program, we began with the upper extremity instabilities, and we talked about the instabilities of the shoulder. In session number 2, we moved down into the elbow and discussed the AMA guides and their descriptions and discussions of elbow instabilities. And then in session 3, we began our discussion of the carpal instabilities. And the carpal instabilities are a little bit more complex, so that's taking 2 entire sessions to handle the carpal instabilities. In session 1 on carpal instabilities, we talked about what the AMA guides referred to as the dissociative forms or dissociative patterns of carpal instability, and that included scapholunate dissociation, lunotriquetral dissociation, and proximal carpal row dissociation as a result of scaphoid fracture and either non-union or deformed healing of a scaphoid fracture. All of these can create dissociations amongst the proximal row of carpal bones, and these dissociations can be determined both on physical examination and with X-ray measurement findings. And the AMA guides provide us with the measurement findings against which we can compare our examinees' findings to assess for permanent impairment. So that was session number 1. And in today's session, I want to pick up where we left off and introduce a new concept to you, and that has to do with the non-dissociative carpal instabilities. So just to review, the difference between dissociative and non-dissociative carpal instabilities is that the dissociative instabilities involve an injury between adjacent carpal bones. Typically, we see this in the proximal row of carpal bones, where we have an injury to the interosseous ligaments that restrain adjacent interosseous bones. So the AMA guides describe injury to the scapholunate ligament, which results in scapholunate dissociation. The AMA guides also describe lunotriquetral dissociation, which is secondary to an injury to the lunotriquetral ligament. Okay, so those are the dissociative patterns of carpal instability. The non-dissociative patterns of carpal instability involve injury and dissociations, loss of anatomic relationships between the rows of carpal bones. So for an example, we can have an injury to the extrinsic ligaments that span from the proximal carpal row to the distal carpal row, creating a loss of anatomic relationship between the proximal and distal row. Also, we can have an injury to extrinsic wrist ligaments that span the articulation from the radius or the ulna to the proximal carpal row, resulting in a loss of anatomic relationships between the proximal radius and ulna and the proximal carpal bone. So these are the non-dissociative forms of carpal instability. And the AMA guides provide for permanent impairment ratings for both the dissociative and the non-dissociative forms of carpal instability. So let's pick up with the 2 major patterns of non-dissociative carpal instability that are described in the AMA guides. which has to do with the VISI, V-I-S-I deformity, and the DISI, D-I-S-I deformity. That's the ventral intercalated segmental instability, or the dorsal intercalated segment instability, with the intercalated segment being the lunate bone. So there's a little hint as to where we're going. These non-dissociative forms of carpal instability have a lot to do with the lunate bone. Okay? So let's pick up with today's discussion of the non-dissociative carpal instabilities. Okay, so let's begin with today's discussion of the carpal instability non-dissociative pattern. Okay? Now, the non-dissociative carpal instability patterns are characterized by a symptomatic disruption not within carpal rows, such as the dissociative forms, but the non-dissociative forms are characterized by symptomatic disruption between either the distal radius and ulna and the proximal row of carpal bones. Okay, so here's the distal radius and ulna, and here's the proximal row of carpal bones. That would involve a disruption between those articulations, or between the proximal carpal rows and the distal carpal rows with a dissociation there. So these are dissociations that span articulations, whereas the dissociative forms of carpal instability are within the bones of each carpal row. Okay, so the common patterns of non-dissociative carpal instability that are described in the literature and also in the AMA guides involve the VISI instability pattern and the DISI instability pattern. With the VISI pattern, VISI stands for ventral intercalated segmental instability pattern, where the intercalated segment refers to the lunate bone, and the lunate bone is flexed ventrally, palmar word. It's a deformity where the lunate bone is flexed palmarward. In the DISI deformity, the opposite exists, where the lunate bone is extended dorsalward, excessively extended dorsalward. So the key bone in these instability patterns is the lunate bone. Now, also in the literature, there is described what's referred to as the combined carpal instability non-dissociative pattern, but the AMA guides do not discuss it, and the AMA guides do not provide findings indicative of a combined carpal instability non-dissociative pattern, which has to deal with a combination of disruptions. A disruption not only between the distal radius and ulna and the proximal carpal bones, but an additional disruption between the proximal carpal bones and the distal carpal row. So this is obviously indicative of a more severe injury, with injury to both the volar and dorsal carpal ligaments. So I mentioned that here just for your own education and edification, but from here on we'll limit our discussion to those patterns that are described in the AMA guides, which is the VISI and the DISI deformities. Okay, so let's take a look at these wrist extrinsic ligaments that are involved with these non-dissociative carpal instabilities. Okay, so here we have a couple of diagrams. The one on the left is showing the palmar aspect of the left hand, and the one on the right is showing the palmar aspect of the right hand. So left and right. And they basically show the same ligaments and the same anatomic structures, but one is in slightly more anatomic detail than the other. But let's just go through these and take a look at these ligaments that become involved in these non-dissociative carpal instabilities. So with non-dissociative carpal instabilities, we're dealing with injury between the radiocarpal articulations here and the ulnocarpal articulations here. And then we're also dealing with injuries, intercarpal injuries, with injuries between the proximal and distal row of carpal bones here. So the injury would be along these lines and along these lines for these non-dissociative carpal instabilities. So if we're talking about the distal radius and ulna and the proximal row of carpal bones, we're talking about, for example, injury to the short radio-ulnar radiolunate ligament here. We're dealing with perhaps injury to the long radiolunate ligament here. We're dealing with injury to, for example, the ulno-lunate ligament here. And notice that many of these ligaments center on the lunate bone. As we said in our last slide, that the intercalated segment is going to be involving the lunate bone. So you can see how the lunate bone can become dissociated from the distal radius and ulna with an injury here to all of these radiocarpal and ulnocarpal ligaments. In addition to those, here we have an ulnotriquetral ligament down here, which goes on up to the triquetral bone. We have an ulnopisiform ligament here. We have a radioscaphoid ligament here. And those are simply ligaments that span the articulation between the distal radius and ulna and the proximal row of carpal bones. And in addition to those ligaments, we have ligaments that span the articulation between the proximal and the distal carpal rows. So for example, we have here is the scaphocapitate ligament. And here is a scaphotrapezoid ligament. And here is a scaphoid trapezium ligament. And here is a piezohamate ligament and a triquetrocapitate ligament. And these are ligaments that span the articulations between the proximal and the distal rows. So you can see that with an injury here to these ligaments, we're going to have a dissociation between the proximal and the distal row of carpal bones. Well, in addition to those, we also have ligaments that span the articulation from the distal radius and ulna all the way to the distal row of carpal bones. So for example, we have here the radioscaphoid capitate ligament here that spans now two articulations. And then, for example, here we have an ulnocapitate ligament here, which spans two articulations. And this is just an example on the volar aspect of the hand. You can imagine that the pattern and overlapping arrangement of ligaments on the dorsal aspect of the hand would also be similar. So this gives us a good anatomic representation of where these injuries occur and how these injuries affect these consecutive articulations between the radius and ulna and the proximal row of carpal bones, and between the proximal row of carpal bones and the distal row of carpal bones. And in the combined forms of non-dissociative carpal instability, we have dissociations involving all of the articulations between those landmark structures. And with the VISI form, the ventral intercalated segmental instability form of non-dissociative instability, we have an injury between the proximal and the distal carpal rows. So this is referred to as an intercarpal or a midcarpal injury. An injury between the distal radius and ulna and the proximal row of carpal bones would be referred to either as a radiocarpal or an ulnocarpal injury. So here we're dealing with a midcarpal injury, which is an injury between the proximal and distal row of carpal bones. So if we refer back to the prior diagram with the ligaments, we know that this involves an injury to the triquetral hamate ligament, to the triquetral capitate ligament, or perhaps between either the scaphotrapezium or scaphotrapezoid ligaments. So any one or any combination of injury to those ligaments can cause a dissociation between the proximal and distal row of carpal bones. Now, when the wrist goes through its normal ranges of motion, specifically from ulnar to radial deviation, the disrelationship of these proximal and distal carpal rows can manifest itself and can be detected by physical examination. So it's important to know that normally with ulnar deviation of the wrist, the proximal row of carpal bones rotates from a position of flexion of the carpal bones into a position of extension. So the proximal row of carpal bones are in maximum extension at maximum ulnar deviation. Well, with injury to the intercarpal ligaments, such as the triquetral hamate ligament or the triquetral capitate ligament, these ligaments fail. When these intercarpal ligaments fail, the proximal row is no longer pulled into extension with ulnar deviation. It's no longer pulled into extension because of a lack of restraint of the midcarpal ligaments. So instead, the proximal row of carpal bones remain palmar flexed during ulnar deviation until the wrist reaches the extreme of ulnar deviation, and then the proximal row abruptly rotates into an extended position, producing a palpable catch-up clunk in the process. And this is going to form the basis of our provocative maneuver for the assessment of this visci instability pattern. Okay, and on physical examination with injury to these midcarpal ligaments, the examinees typically will report ulnar-sided tenderness, and they'll often report a painful clicking with combined movement of forearm pronation and wrist ulnar deviation. Remember, it's the wrist ulnar deviation which causes the change in the movement pattern between the proximal and distal carpal rows. So the provocative maneuver that's going to elicit this dissociation, it's going to elicit this instability, is known as the midcarpal shift test. So to perform the midcarpal shift test, the examiner passively translates the pronated wrists, here's the pronated wrist, passively translates the pronated wrist in a palmar direction. So it's hard to demonstrate this with only one hand, but you as the examiner would stabilize the distal radius and ulna here, and then would passively translate the wrist palmarward, pre-stressing the dorsal carpal ligaments. Okay? Then the wrist is slowly and passively moved from neutral or radial deviation into ulnar deviation, and at the extreme of ulnar deviation, you'll typically elicit the classic catch-up clunk as the proximal row then abruptly shifts into extension, as all of these bones in the proximal carpal row, the scaphoid, the lunate, and the triquetrum, all passively rotate into extension abruptly. Whereas without injury to the midcarpal ligaments, there's a very gradual and fluid movement of the proximal row of carpal bones from flexion to extension as the wrist goes from radial to ulnar deviation. In the literature, they describe stress radiographs, meaning clenched fist radiographs, in varying degrees of radial and ulnar deviation to be able to assist in the diagnosis of this condition. The AMA guides, and I'll show you the reference in just a minute, the AMA guides refer to this visci deformity as involving a negative radiolunate angle, So with a negative radiolunate angle, the lunate remains in flexion for this visci deformity. So the AMA guides do describe X-ray measurement findings for the identification of this visci deformity, and the visci deformity involves a ventral or palmar flexion of the lunate in relationship to the radial bone. the radial bone. So the radiolunate angle becomes disrupted with a visci deformity. Okay, so here we have a table and a figure from the AMA guides. This is table 1625. And here they describe some findings consistent with the visci pattern of non-dissociative carpal instability. So here, under the description of the radiolunate angle, they tell us here that with a visci deformity, we see a negative radiolunate angle, meaning that the lunate remains in a flexion position when the wrist is somewhere between the extremes of radial and ulnar deviation, such as when the x-ray is taken with the wrist in neutral, neither radial nor ulnar deviated. So the lunate remains in a flexion position, giving us a negative radiolunate angle. Well, the AMA guides tell us that the normal radiolunate angle is from 0 to 10 degrees, with 11 degrees either positive or negative angle, qualifying for a mild carpal instability. So here in figure 1651 of the AMA guides, they show the lunate bone here with a radiolunate angle here of approximately, what would you call that? What would you call that? Just a couple of degrees, maybe somewhere between 0 and 10 degrees. So when this lunate is in a normal position of either rotation in this direction toward the negative angle direction, or in rotation in this direction towards what would be a positive angle direction, 0 to 10 degrees in either direction is the normal range of position of the lunate bone. Well, when the lunate bone is in a greater rotation in this direction, giving us a negative radiolunate angle, that represents a visci deformity, such that the lunate bone would be more rotated, such as this. I know that's a poor drawing, but can you see that this represents a rotation in that direction of the lunate bone? So that is a ventral intercalated segmental instability. And then, of course, the opposite, with a rotation of the lunate bone in this direction, would be a dorsal intercalated segmental instability, and that would be manifested by a positive radiolunate angle. And when the angle is positive greater than 10 degrees, that qualifies as a disci deformity, which is a mild carpal instability impairment. So that's the visci deformity. Now with the disci deformity, unlike the visci deformity, the proximal row of carpal bones remains normally aligned throughout its motion arc, but as the wrist extends, as the wrist moves from radial to ulnar deviation, we see a dorsal subluxation of the capitate bone. As the proximal row of carpal bones extends, goes through its normal range of motion from flexion to extension as the wrist goes from radial to ulnar deviation. And this is due to insufficiency now not of the ventral carpal ligaments, but now of the dorsal intercarpal ligament. The ligament that goes and spans between the proximal and the distal row of carpal bones. In addition, there's failure of the long radioscaphocapitate ligament, which now spans both articulations between the radiocarpal articulation and the midcarpal articulation, and failure of this radioscaphocapitate ligament right through here. Here's the radius bone, the scaphoid bone, and the capitate bone. Failure of this ligament creates excessive laxity at the capitate bone in a region known as the space of Poirier. So this laxity in the space of Poirier is what's going to allow dorsal subluxation of this capitate bone as the wrist reaches its extreme of ulnar deviation. Now, the AMA guides tell us that certain individuals may have wrist pain and loss of strength related to a dynamic or non-dissociative carpal instability that cannot be measured by changes of angles on static röntgenograms. So we went over a couple of the angle findings for both the VISI and the DISI deformities that can be measured. But an absence of lunate flexion or lunate extension angles on static röntgenograms does not necessarily preclude or rule out the presence of a non-dissociative carpal instability pattern, in which case, even when static röntgenograms are normal, we can provide for a permanent impairment rating for a non-dissociative carpal instability pattern based on physical examination findings, typically which involves painful clicking and clunking with activities of daily living and also with physical examination maneuvers. So these are examinees who are going to complain of wrist pain, wrist clicking, wrist clunking, pain with grasping maneuvers, particularly when the arm is in supination. Now, in the literature, the typical examinee who presents with a non-dissociative carpal instability are usually younger examinees with bilateral hypermobile wrists. In other words, they have ligamentous laxity at the wrist. In the industrial setting and workers' compensation, this is going to be a symptom pattern and an injury pattern that's found after trauma to the wrist. So after trauma to the wrist, even though there may not be findings on static X-ray radiograph measurements, the examinee will still complain of symptoms, and the physical examination will be consistent with clicking and clunking on provocative maneuvers. And the provocative maneuver associated with this DISI deformity is the dorsal capitate apprehension displacement test, or dorsal capitate displacement apprehension test. Okay, so to perform this maneuver, you as the examiner is going to apply dorsal pressure to the scaphoid tubercle. So here the examiner has his left thumb applying pressure in a dorsal direction to the tubercle of the scaphoid bone. So with dorsal pressure applied, the examiner then applies a longitudinal traction to pre-stress the radiocarpal and the intercarpal ligaments. Then the examiner places the wrist in flexion and applies ulnar deviation. And as the wrist approaches its maximum range of motion in ulnar deviation, a painful clunk will be noted as the capitate bone subluxates in a dorsal direction due to excess ligamentous laxity in the space of Poirier. And on diagnostic radiographs, the lateral radiographs, this is according to the AMA guides, the lateral radiographs will demonstrate a positive radiolunate angle, as the lunate bone is in a position of extension on these neutral non-stress radiographs. Okay, so let's take a look at this. Okay, so here the AMA guides tell us that a positive radiolunate angle greater than 10 degrees represents a DISI deformity. And with a DISI deformity, the lunate bone is in a position of extension deformity. So here's the lunate bone here. With a DISI deformity, the lunate bone is rotated in this direction into an extension deformity, opening up and creating a wider radiolunate angle. This would be the radiolunate angle here in a positive direction. And when the radiolunate angle is greater than 10 degrees, for example 15 degrees, it qualifies for a mild carpal instability. Qualifies for permanent impairment due to mild carpal instability. Remember that the normal range of motion, the range of normal values for the radiolunate angle is from positive 10 degrees to as many as negative 10 degrees. So from here to here is considered a normal anatomic positioning of the lunate bone. So with a dorsal or an extension subluxation of the lunate bone, we have a dissi deformity in this direction. With a extension angle and a negative radiolunate angle, we have a visci deformity in this direction, both of which qualify for permanent impairment ratings. So those are the visci and the dissi forms of non-dissociative carpal instability patterns. Finally, the AMA Guides describes a third type of non-dissociative carpal instability pattern, and that is the pattern of ulnar translation. Ulnar translation is given a permanent impairment rating here under table 1625. So let's just say a couple words about ulnar translation. So ulnar translation may occur secondary to injury or secondary to arthritis, such as rheumatoid arthritis. It's measured on the neutral P to A view with the fist forcibly clenched. So this needs to be part of your routine views when ordering wrist x-rays for the assessment of carpal instability. Now, the guides tell us that normally greater than 50% of the lunate bone overlies the ulnar border, the ulnar aspect of the distal radius. So picture the distal radius and the distal ulna in your mind, and you can take a line down the middle of the axis of the radius bone and divide that into a radial half and an ulnar half. And usually greater than 50% of the lunate overlies the ulnar border of the distal radius. Okay? As ulnar translation becomes more severe, progressively less and less and less of the lunate overlies the distal radius bone. The grades of severity of upper extremity impairment are classified as mild, wherein less than 50% of the lunate overlies the distal radius ulnar border. A moderate carpal instability pattern, wherein less than 25% of the lunate overlies the distal radius ulnar border. And a severe ulnar translation impairment, wherein the lunate is displaced completely off of the distal radius in an ulnar direction. Or the guides phrase it by saying that the lunate is displaced ulnarly off of the radius bone. And here is the different impairment values for ulnar translation. Mild ulnar translation qualifies for 8% upper extremity. Moderate ulnar translation qualifies for 16% upper extremity. And severe ulnar translation qualifies as 24% upper extremity impairment. Okay, so table 1625 describes the non-dissociative carpal instabilities as being assessed through measurement of the radiolunate angles and through assessment of ulnar translation, whereas the dissociative forms of carpal instability are described through measurements of the scapholunate angle, scapholunate gap, and the triquetro-lunate step-off, as well as an overlapping measurement involving the radiolunate angle. So the radiolunate angle can be used to assess both the dissociative and the non-dissociative forms of carpal instability. Okay, so let's take a little closer look here at ulnar translation and see how that presents anatomically. Okay, so here we have an image of the volar aspect of the left hand. Here is the pisiform bone here. with the thumb here. So this tells us this is the palmar aspect of the left hand. And what we see here is disruption of some radiocarpal ligaments. So for example, this is a radiotrapezoid ligament. This would be a radioscaphocapitate ligament. This would be a radioscapholunate triquetral ligament here. So with disruption of any and or all of these ligaments, we see a dissociation and a disruption and a loss of anatomic relationship between the radius bone and the entirety of the carpus. Well, with the lunate bone here as our reference bone, as this lunate bone becomes progressively less and less stabilized by the ulnar border of the distal radius here, we see greater and greater impairment due to ulnar translation. So in this particular image, we see that if we draw a line down through the lunate bone, we see that approximately less than 50%, probably more like 30% of the lunate bone remains in congruity with the ulnar border of the distal radius. And you might argue that it's even less. You might argue that more than 75% is translated off of the ulnar border of the distal radius. As the lunate progressively moves in an ulnar direction off of the distal radius, the examinee would qualify for greater and greater severity of ulnar translocation. In this case, this appears to be what I would classify as a moderate ulnar translocation. So this is a measurement finding that you take on the neutral P to A stress radiograph, which is not one of the routine views that imaging facilities routinely order for assessment of the wrist, but imaging facilities don't routinely assess for carpal instability and or ulnar translation. So when you order these imaging studies for your examinees, make sure that the imaging facility is fully aware of the necessary images that you need for the assessment of these various dissociative and non-dissociative forms of carpal instability, including in this case ulnar translation. Okay, so finally, in addition to permanent impairment ratings associated with mild, moderate, or severe carpal instability patterns, whether those instability patterns be of the dissociative or the non-dissociative type, what other permanent impairments would you expect an examinee who suffered a severe injury to their wrist? What other types of impairments would you expect that examinee to present with? Well, this is not an exhaustive list, and your findings may vary, but some of the types of impairments may include a loss of range of motion of the wrist, either excessive range of motion or perhaps reduced range of motion. Some of these examinees may have concomitant digital nerve lesions of any or multiple digital nerves. They may present with peripheral nerve injury, typically involving either the median nerve, the ulnar nerve, or perhaps even the radial nerve in the case of injury to the dorsal aspect of the hand. They may present with vascular disorder. Now, the AMA guides tell us that under the strict application of the AMA guides, impairments due to carpal instability cannot be combined with impairments due to loss of strength or loss of grip strength, and cannot be combined with permanent impairments due to permanent impairment rating due to pain. But under Alvarez and Guzman, as you know, we have great liberty and great laxity to apply alternative impairments, even disregarding some of the instructions that are provided in the AMA guides, if in your opinion and within reasonable medical probability, those impairments are a more accurate description of the examinee's true condition. So perhaps, even though the guides tell us that loss of strength and loss of grip strength cannot be combined with impairment ratings due to carpal instability, you may opine that perhaps an alternative impairment rating due to analogy to hernia, involving now a loss of lifting capacity involving the upper extremity or upper extremities, plural, could be a more accurate description of the examinee's impairment, even when the guides tell us that these particular impairments cannot be combined. So the point on this is that under Alvarez and Guzman, and within the four corners of the AMA guides, we have great liberty and great freedom to exercise our clinical judgment and experience in providing for an accurate description of the examinee's true impairment. And so your use of the four corners of the AMA guides may employ alternative descriptions in addition to the permanent impairment rating provided for simply by the AMA guides descriptions of carpal instability. Okay, so feel free to exercise your clinical muscles and your clinical experience in providing for what you determine to be the most accurate description of these wrist injury cases. Okay, so doctors, I hope this helps you in your assessment of your wrist injury cases. Now, the AMA guides require that we order diagnostic wrist x-rays for the assessment of carpal instability patterns. However, the AMA guides do not require that we identify alterations in these various angles and these various measurements in order to provide a permanent impairment rating for a non-dissociative form of carpal instability pattern. So the AMA guides provide for permanent impairment ratings for non-dissociative carpal instability, for dissociative carpal instability, and then, in my opinion, and at least under Alvarez and Guzman, you could provide for a permanent impairment rating for a combined non-dissociative carpal instability pattern by combining some of the impairments that are described in the AMA guides, by stacking and adding the impairments that are described in the AMA guides. Now, the AMA guides tell us that only one instability pattern can be used at a time, but it's my opinion that under Alvarez and Guzman, you could add and combine multiple findings on these static rankinograms in those severe wrist injury cases that result in, for example, a combined non-dissociative instability pattern. So if you have an examinee who suffered a severe wrist injury and he has findings of a dissociative carpal instability pattern, in other words, he has disruptions in the scapholunate angle or increase in the scapholunate gap, or perhaps alterations in the lunotriquetral angle, and has findings for ulnar translation, and or has findings for a Vissi deformity due to alterations in the radiolunate angle, or has findings for a Dissi deformity due to alterations in the radiolunate angle. What prevents you under Alvarez and Guzman from either combining these multiple impairments or even adding these multiple impairments if, in your opinion, that it results in the most accurate description of the examinee's true condition at the time that you determine the examinee to be permanent and stationary? So we have great flexibility both under the AMA guides and certainly under Alvarez and Guzman in using these carpal instability patterns to provide for permanent impairment ratings for our examinees who suffer these wrist injuries, which will likely never get well and which will likely only worsen over time. So when you have an examinee who reports pain in the wrist, and especially if they describe clicking and clunking with activities of daily living, this should sharpen your thinking to the potential for a carpal instability condition, So in those cases, make sure to order the necessary radiographs, and make sure to order the radiographs that are exactly described in the AMA guides, and perform all of those measurements for the assessment of carpal instability yourself. Don't delegate this to the medical radiologist. Don't delegate this to any third party, but make these measurements yourself. And there are so many good reasons, which we don't have time to go into in this discussion, as to why you should take these measurements yourself. So make sure to perform these measurements yourself. Okay? So, doctors, this concludes our discussion of the upper extremity instability patterns. We fully handled the shoulder, the elbow, and now the wrist. And so I'm certain that you're going to find this helpful in the evaluation of your upper extremity cases. In our next session, we're going to begin our discussion of the lower extremity impairments, and we're going to discuss knee instability and ankle instability. And then in our final segment of this course, we're going to go into the spinal instabilities. So I'm sure you're going to find that to be very helpful. So I want to thank you for taking the time to join me on this series of discussions. I look forward to being with you in our next series of discussions as well. And for now, this is Dr. Perry Carpenter, wishing you best of success in your career as a qualified medical evaluator.